Hello and welcome everyone to our next AC Forum webinar series. This webinar is titled Navigating the 2024 PAD Guidelines. My name is Jeffrey Barnes. I am a cardiologist and vascular medicine specialist at the University of Michigan. I'm also on the board and the president-elect of the Anticoagulation Forum. And I'm joined today by my co-moderator, Dr. Arthur Allen, somebody everyone here knows, who's the anticoagulation program manager at the VA Salt Lake City Healthcare System, also a board member and chair of our webinar committee. Today, we have two amazing panelists who are joining us. The first is Dr. Herbert Aronow. He's the immediate past president for the Society of Vascular Medicine, or SVM. He is also the medical director of the Heart and Vascular Service at the Henry Ford Health System here in Southeast Michigan. And we also have Dr. Amy Pollak. Dr. Pollak is the director of the Women's Heart Clinic and the director of the Community and Comprehensive Cardiology Clinic at Mayo Clinic, Florida. She's also the chair of the AHA's PAD National Action Plan. Herb and Amy, thank you guys so much for joining us on today's webinar.
Thanks, Jeff. It's really great to be here, and I know we're going to focus on the guidelines. I just want to acknowledge Heather Gornick, who chaired that effort, and also Phil Goodney, who was my co-vice chair, and the rest of the writing group, of which Amy was an important part.
Thrilled to be here, and just definitely want to echo just a huge thanks for the wonderful leadership of the PD guidelines. So excited to be here.
Well, that is great. So, Herb, as you mentioned, these are the update from our 2016 guidelines led by the American College of Cardiology, American Heart Association, but also several other societies that are really instrumental in this space. And you can see all of those societies listed there on the left. These guidelines were published here last month. They're both in JACC as well as in circulation. We've got a link in there for everyone. And as you mentioned, you served as the co-chair. So we've got you highlighted up there. And Amy, you were one of the writing committee members. But we can see this was really a diverse group of experts who came together to provide really insights across multiple avenues of how we care for patients with PAD. And so we're going to focus on one area today, which is largely around the antithrombotic therapy. But these guidelines, when I read them, were extremely comprehensive around all aspects of, who's at risk, how do we approach the diagnosis, how do we think about management in all of its different facets. And so I'd really encourage folks to check it out. Also, before we get into some of the details, I really want to let all of our attendees know that you can participate as well. Please go to that Q&A button and enter any questions that you have. After we get through the first set of cases that we're going to discuss, then Arthur's going to come back and do a moderated Q&A session. So your questions will be able to answer at that time. So go ahead and put those into the Q&A if you have a chance. Well, Herb, before we get into some of the cases, I'm wondering if you could help us understand a little bit about how this guideline was put together, and in particular, help us think through both the class of recommendation and the level of evidence, both of these sort of qualifiers that we see associated with any of the recommendations in a guideline like this.
Yeah, thanks, Jeff. What you're seeing in front of you here with regard to the class of recommendations, or COR, and the level of evidence, or LOE, is the standard approach that we take across all ACC/AHA guidelines. And so if I start on the left side of this slide with the strength of recommendation, you can see from the top to the bottom, we move from class 1, which is in green. That's a strong recommendation where the benefit far outweighs the risk at one end of the spectrum, to the other end at the very bottom here, where you've got class 3, which can either be class 3 because there's no benefit, that's shown in orange here, that means the benefit equals the risk, or class 3 where there's clearly a harm, and that's a strong recommendation where the risk is greater than the benefit. And the in-between classes of recommendation are the class 2A, class 2B, which are moderate and weak recommendations where there is more benefit than risk, but it's not as strong as, let's say, for a class 1. Now, in parallel to that, on the right side of the slide, there's the level of evidence to support those recommendations, and that tracks from A to C. So A, as an example, might be multiple randomized trials that support something, and B might be a single randomized trial, or perhaps a meta-analysis. And you can see, as you track down there, you get to C, where now we're talking about limited data, or LD, or maybe we're talking about expert opinion, or EO. It's important to recognize that a class 1 recommendation doesn't necessarily mean there's level of evidence A. You could, for example, have a recommendation like you shouldn't jump out of a plane without a parachute, okay, but we might not have any data to back that up. It might just be expert opinion. So you could have a level C level of evidence backing up a class 1 recommendation.
Great. I think that's really helpful because each of the different guidelines we often see sometimes use different approaches. And so understanding how these recommendations are qualified really helps us put them into perspective for our clinical practice. You know, Amy, I thought I would turn to you and help us understand a little bit about the different clinical classes of peripheral artery disease or PAD. You know, it's not just one entity. There's actually a couple different groups, and that's going to be important as we think about when and how to apply some of these guideline recommendations. Could you walk us through this briefly?
Oh, absolutely. And I think one of my favorite figures from the guidelines, and there are several, but this is one, because I think as you really kind of spend some time looking at this, you get a sense for just how interconnected the different clinical subsets of PAD can be in the patient's journey with having peripheral artery disease. And if we start at that top left-hand corner, you can see that, get asymptomatic peripheral artery disease. And I think it's an important parenthesis there that these patients may have functional impairment. And like so many other times, they may think they're asymptomatic, but they may have curtailed their level of activity and really cut back so to avoid having symptoms. But so asymptomatic still may have some functional impairment. And then as you move to the right, this chronic symptomatic, and this was really, I think, a bit of a of a change a little bit from how we've been talking about that chronic symptomatic, where in guidelines of years past, it was really kind of stable claudication. And I think that this guidelines was really wanting to promote the this idea that chronic symptomatic lower extremity peripheral artery disease, oftentimes patients will have symptoms other than kind of cramping calf muscle pain or leg pain as they're walking. It's importantly many other exertional leg symptoms, even just including fatigue and leg heaviness. But so it's asymptomatic to then chronic symptomatic. And then we start to get into the red zones, that where you're starting to really have ischemic legs. And so that ALI, or acute limb ischemia, this is the equivalent of a leg attack. So this is, time is tissue, and we really have got to get restoration of blood flow. So then acute limb ischemic event. And then chronic limb threatening ischemia. This is more of that going on for weeks to months, and oftentimes patients will have sores or ulcers, even gangrenous digits on their feet, and you can see for a given patient, their journey may just be in one lane of chronic symptomatic, but they're certainly at risk for having ALI or CLTI.
And I think this figure nicely highlights that people can jump between these different boxes, right? There's not sort of this one directional pathway. Sometimes you can go from asymptomatic to ALI right away, or chronic symptomatic to CLTI. I mean, do you see your patients jumping back and forth sometimes between these?
It definitely can. I mean, you want to aim to prevent those acute limb ischemic events or CLTI, but you're absolutely right. You can jump multiple directions, and I think that really speaks to the importance of just an ongoing conversation and education with patients and their family members, that they may be in this chronic symptomatic but are at risk for ALI, and what can we do to prevent that acute limb ischemic event?
I just add to Amy's comments that I think I really like this way of breaking down the manifestations of the disease, because obviously our approach to the patient, both from a diagnostic and a therapeutic standpoint, is going to depend on which box they happen to be at any one point in time. I think the second take home here from the upper boxes, the asymptomatic and chronic symptomatic, is that this is what makes it so hard to have accurate estimates of how prevalent the disease is, right? Is that there's so many people, as Amy said earlier, that may seem asymptomatic, but they actually may have functional impairment. We just don't know because they've ratcheted back their activity. So I agree. One of my favorite figures from the guideline document.
Oh, that's great. Well, let's turn to our first case here and let's see how the guidelines help us think through this case. Herb, I'll maybe pitch this one to you. This is a 76-year-old man. He's coming to clinic with a history of diabetes and coronary disease. He actually had a coronary stent placed about 6 months ago, and he's just coming for his routine clinic follow-up. Now, he has a past medical history of stage 3 chronic kidney disease. So he's in that moderate chronic kidney disease range. So as you think about this gentleman, what are some of the risk factors for PAD that you're already picking up on? And how should we be thinking about doing any evaluation for a patient like this?
Yeah, great questions, Geoff. Clearly, older age, type 2 diabetes, and CKD are all going to increase the likelihood that this patient has PAD. Having coronary disease, or if this patient had cerebrovascular disease, atherosclerosis in another vascular bed is obviously going to increase their risk as well. It's not necessarily a risk factor for, but it's a marker that they have athero, right? So there's lots going on in this 76-year-old man that make you think there could be underlying PAD. And so that takes us to how do we sort that out? And it starts with the history. And I would say there's some very important questions we need to be asking. As we highlighted on the last slide, it can be subtle. So how you ask may result in a different outcome. You really need to ask patients about, for example, when they ambulate, are they limited in any way? And let them tell you why. And they may describe that claudication in any number of ways, and it might not have been the words you would choose. So it's important, I think, to ask open-ended questions there. You're obviously going to want to know about the classic symptoms as well. Calf cramping as an example, or rest pain at night, etc. But the history is only one component of this, and the physical obviously will be critical as well. It's really important. It may sound basic, but it's really important to take their socks and shoes off, and to do a full evaluation head to toe, auscultating for bruits, which may indicate underlying atherosclerosis in any vascular bed, including in the lower extremities. It's important to palpate their pulses and determine where they're diminished. You can determine a whole lot even in advance of non-invasive vascular testing just with a good physical exam. If, for example, in the legs, you start by palpating the femoral artery pulses and you work your way down to the popliteals and then the pedals. I mean, if there's an occlusion there, you'll often know it before you see that from an ultrasound study. And then finally, I think it's important to move toward diagnostic testing. So an ABI, or ankle brachial index, is really a critical part of this, where you're measuring what happens to the pressure when we compare that in the brachial arteries to that all the way down at the level of the feet. It won't tell you at what level the problem occurs, but it will tell you if there's a decrement beyond what you'd expect. And you wouldn't expect more than a 10% decrement or an ABI of 0.9 to be apparent. If their ABI is 0.9 or less, then that's typically diagnostic.
And Herb, I realized as I was looking through the guidelines, doing this comprehensive history, good physical exam, looking at the legs and feet, these are class 1 recommendations that, of course, as physicians and as advanced practice providers, we are thinking about doing in the clinic all the time. But a lot of this is stuff that all of our clinical colleagues can pick up on, right? You can recognize these risk factors, you can pick up on some of these history elements, and then sort of clue people in to say, we need to do more investigation. And do you really see a multidisciplinary approach to using this information?
There is absolutely a need for a team approach, both across multiple disciplines and multiple specialties here. And so, we're describing just one aspect of that. You're the provider in the office. This is the history you take. This is, these are the physical exam findings you're looking for. But once you have a suspicion, at whatever point it is, whether it's after your history, your physical, or that diagnostic testing perhaps you sent them for based on your suspicions, then it's important to pull in others depending on which way you're headed. And I know we're going to talk a lot about that, about medical therapy, about revascularization, about wound care and foot care. And so depending on the individual patient, there are a whole host of needs that are better served if we approach this as a team.
That's great. Amy, I want to go back to the same case and I want to add a little bit more context. So this isn't just a 76-year-old man. This is a 76-year-old Black man. And he happens to live in Mississippi. He's currently working as a janitor and he's still smoking 1 pack per day. And so as you look at this more full picture of this particular patient story, what are some of those PAD risk amplifiers that are starting to come out to you? And what does it mean when we use this term PAD risk amplifier? That might be new to folks. And then what are some factors that are contributing to health disparities, specifically around PAD for somebody like him?
No, I think this is such an illustrative part of the case because, to your point, as we're thinking about, peripheral artery disease and risk enhancers, we know that there are critical health disparities where, unfortunately, when you look at a map of our country, there are much higher rates of limb loss related to peripheral artery disease in certain parts of the country, in particular, kind of what we've historically thought about as the stroke belt. So in the southern part of the United States, so the fact that he lives in Mississippi, that definitely has my attention. He's actively smoking. We know that there's a prothrombotic just milieu from active tobacco use. And this is definitely another one of my favorite figures from the guidelines because we as a writing group under our just excellent chair's leadership, we all spent a lot of time on this figure because I think it is so important as we're thinking about kind of the whole person. We're talking specifically right now about lower extremity peripheral artery disease, but fundamentally, as we're caring for our patients, we're wanting to reduce their risk of all cardiovascular events, whether it's stroke, heart disease, and then limb-related events. And so I really have liked this visual of this heart brain leg connection. And I think that really makes sense, not only to me, but to many patients where things can seem like, well, gosh, I'm having to worry about not having a stroke and then my heart. And then what in the world is going on now with my legs? I have to worry about these two. And I think just really kind of anchoring it that arterial tree is really that heart brain leg connection, and our risk of having peripheral artery disease events are certainly related to health disparities and these PD risk amplifiers. So we'll just kind of go through the health disparities one by one on the left-hand side of the screen. We know that race and ethnicity are related to worse events with peripheral artery disease, much higher rates, about 4 times the rate of having an amputation related to PAD for Black Americans. Certainly Hispanic Americans and American Indians are also at increased risk of worse outcomes related to peripheral artery disease. We talked some about geography, and then it's certainly a whole nother kind of dedicated conference or webinar about structural racism and implicit bias and how that it really is related to the health disparities and some of what we're seeing geographically. And then social determinants of health. This is absolutely that undercurrent that is affecting all of our health outcomes and has to do with chronic stress, lower quality education, health literacy, lower income, less access to quality housing, limited access to food and exercise, health insurance, access to health care, and that impact of health on jobs and workplace. And for the patient in this scenario, he's it has that ongoing tobacco use now for that right side of the screen for PD-related risk amplifiers. His chronic kidney disease. He has probably polyvascular disease. We know he's got coronary disease, and it sounds like we're kind of aiming up or gearing up to say that he has peripheral artery disease. And so we're really painting a clinical picture of a gentleman who is at really increased cardiovascular risk. For me, that polyvascular disease with active tobacco use, we're at kind of the pinnacle of our cardiovascular risk. And so that's going to definitely change how aggressively I'm going to want to treat his risk factors.
And as I think about especially the left and bottom side of this, I know there are several national efforts that are ongoing and you're helping to lead those through the National Action Plan. Are there things that individual clinicians can do to try and address some of this? I mean, if you just had to have maybe one piece of advice that a nurse, a pharmacist, a provider could do, anything you would recommend?
So it's a great question, and you're right. Where I'm very excited about the work that's being done by a whole about 17 organizations, and the American Heart Association has been helping to serve as a convener for this as part of the National Action Plan for PAD and the PAD Collaborative. You know, I think that for an individual practitioner or provider, I think that one of the things that I've been learning over this last year was that how the language we use really matters for what resonates with patients. We have some really interesting work that'll be coming out soon as we've been doing different focus groups and patient surveys to understand, because when you talk about PAD with the patient, gosh, it seems so abstract, so obtuse. And it's not something that really is like, oh man, this is an urgent thing. You have PAD. And we're learning that talking about blood vessel issues or the vascular issues with the legs, and it seems to be a way that that resonates a little bit more. Again, kind of tying back in with that heart, brain, legs approach. And then once patients understand how it all ties in, they're like, oh, I get it. PAD. Oh, this is important. But I think the one piece of advice I would share, in addition to the taking your socks off and making sure you're feeling for pulses, and it can be a little intimidating the first time you're really delving into feeling pulse, lower extremity pulses in the feet, especially if you're like, I don't know if I'm feeling it. Is it just because I'm not feeling it, or is it really not there? I think if in doubt, that is a perfect time to get an ABI test, because we don't want to miss that diagnosis. It really can be the difference between, saving someone's limb and then limb loss. So taking the socks off and then kind of talking about PAD in language that patients can understand. You may have a blood vessel issue in your legs or a circulation problem we need to understand, and that can be related to risk of heart attack and stroke.
Yeah, and we want to prevent those leg attacks, right? That's so critical. I love that language. Well, let's move on to our next case. And Amy, I'll throw this one back to you. This is a 68-year-old woman. She has a history of diabetes. She's got some mild CKD, hypertension, and she's coming into your clinic for just general fatigue symptoms. And really what she tells you is that she wants to play with her grandkids, but she's just not able to keep up with them anymore. Her legs are feeling tired if she walks up and down stairs. It's starting to get in the way when she's doing her yard work. She's a woman who's got some mild obesity, and you do that great exam. You take off those socks and shoes, and you find that those pulses in her legs feel weak down in the ankles, but she doesn't have any sores. There's no ulcers on her feet. You do exactly as you recommended. You get that ankle brachial index, and sure enough, she's got decreased pressure. So her ABI is 0.7 on the right, 0.6A on the left. So if I think back to that first figure we looked at, like, which of those 4 types of PAD does she have? How would you classify her?
This is such a great case because she's really telling us the answer. She's saying, I'm not able to keep up with my grandkids. My legs are tired walking up and down the stairs and when doing yard work. So she's symptomatic. She has chronic symptomatic peripheral artery disease. And I think this is a perfect example because I see women like this patient all of the time. And if we were only using the lens of cramping calf muscle discomfort with exertion to say that she's symptomatic from PAD, we would have missed the boat entirely for her. But she definitely has stable chronic symptomatic peripheral artery disease, and we see her ABIs are less than 0.9 bilaterally. And so definitely symptomatic PAD. Thankfully, no ulcers on her feet, no chronic limb-threatening ischemia, but you're outlining several important risk enhancers, diabetes, chronic kidney disease. We don't know much about, race or ethnicity or social determinants of health for her. But I think as we look at what are those next steps for antithrombotic therapy, we're going to need to take all of this into consideration because there are multiple options for next steps for her.
Well, that's a perfect segue. And so now that you've classified her as having this chronic symptomatic PAD, how should we be approaching her antithrombotic therapy? And I think a really important piece of that is when you're recommending a particular antithrombotic regimen, what benefit can you tell her you're hoping to get from it?
So these are such critical questions. So I think fundamentally we want to help reduce cardiovascular events, and we want to hope to reduce limb events potentially. And so that will all factor into what options we talk with her about antiplatelets or potentially antithrombotic agents. And so this is a great chart that you put together, Geoff, that I think is wonderful because it really outlines for symptomatic peripheral artery disease. So that kind of third column in, she's definitely in that population.
Mhm.
You can see there's really multiple options in terms of interventions to use, whether or not it's going to be focusing on antiplatelet or potentially, the dual pathway approach. And that dual pathway has to do with not only an antiplatelet, but also a very, very low dose antithrombotic agent. And you can see as that in that last column, the outcomes for reducing MACE or major adverse cardiovascular events, those we feel like we can really impact from the antiplatelet. But when you're wanting to impact both the MACE and the major adverse limb events, that's when we're needing to think about the dual pathway approach with the low dose rivaroxaban plus the low dose aspirin.
And so as I look at something like this, we've got 4 class 1 recommendation options. Do you do them all? Do you pick one? Like, how are you supposed to approach this? I think some people might look at this and say, wow, there's so much to do. How do you start to sort it out?
Absolutely. So I think it really goes back to what we all try to do with every patient encounter, where we want to have a patient-centered decision making and really understanding essentially that balance between what is somebody's risk for leg events, for cardiovascular events, and then their bleeding risk. And so as we're looking at those risk enhancers and health disparities to try to help us understand who's somebody that's probably going to benefit from that dual pathway approach, where they're going to be at a slightly increased risk of bleeding initially, but interestingly enough, that seems to kind of fade away after that first year or so of being on the dual pathway inhibition. So I look at overall kind of leg event risk, cardiovascular risk, and then their bleeding risk as I'm talking with patients about which one of those, as you said, 4 class 1 indications to use.
Yeah.
I
And
would piggyback on that. Oh, I'm sorry, Geoff. I was
yeah,
just going to piggyback on Amy's comment about the bleeding risk and just emphasize that if we look at that 4th recommendation down from the top, the one about dual pathway inhibition, that if we examine the inclusion and exclusion criteria for the 2 trials that have driven these recommendations, right, Compass and Voyager PAD, that people with high bleeding risk were excluded from those trials. So we just don't know, right? Just like people with stroke recently were excluded from those trials. So yeah, there's always this issue of trying to look at the generalizability of these trial findings, asking ourselves the questions: is my patient who's sitting right in front of me like the patients that were in that trial? And sometimes it's gray, it's a fine line, but there were some clear exclusions, and I think high bleeding risk is one of them and worth emphasizing.
and that might be a great person to pick one of the others up above to use as a therapy instead. Is that right?
Exactly.
Yeah. The last thing when I read the guidelines were really specific in that 4th recommendation that it should be rivaroxaban. They didn't recommend apixaban or dabigatran or edoxaban. And it's not just riva in general, it's rivaroxaban at 2.5 twice a day, plus that low dose of aspirin. And Amy, can you just make sure that we're all aware, like, why is it that particular dosing combination that got that level 1 or the class 1 level A recommendation?
Yeah, you bet. So it's as Herb was saying, it's from the Compass trial, and they
Mm.
actually had 3 arms of the Compass trial. So it was the baby dose of the rivaroxaban, the 2.5 milligrams twice a day plus aspirin in one arm. Then it was the rivaroxaban 5 milligrams twice a day plus the aspirin, and then the aspirin alone. And that kind of net clinical benefit was the best in terms of reduction in cardiovascular events, leg events, as well as that lowest bleeding risk with, if you look at that net for the rivaroxaban 2.5 milligrams twice a day plus the aspirin. But you're absolutely right. It's really important that they're done as a package deal. It's you don't want, and we just don't have data to look at any of the other NOACs in terms of being able to extrapolate. So it's rivaroxaban 2.5 milligrams twice a day with aspirin 81 milligrams a day.
Perfect. Well, let's go back to our clinic here. And Herb, I want to pitch this case to you if you don't mind. This is a 74-year-old man. I'm sure you've seen many cases like this. This gentleman has a history of a AAA repair. He's got some asymptomatic carotid artery stenosis, hypertension, and stable CAD. And now he's coming to see you because he needs stenting of his right iliac artery for his chronic symptomatic PAD. Now, he's currently using 81 milligrams of aspirin. He's on a high potency, high intensity statin with atorvastatin, and he's on lisinopril. And so as you think about approaching his iliac artery stenting procedure, how are you going to approach his antithrombotic therapy? And what unique things do we need to think about to like actually get these guideline recommendations into routine practice, especially around the time of procedures? Oh, I think you might be muted there.
Thank you so much, Geoff.
Of
Yeah, there's a lot in this case. And although you didn't ask me, I do want to comment that this is someone who ended up presenting for a procedure, a revascularization procedure. And you mentioned that this patient has chronic symptomatic disease. So presumably they have claudication. They're functionally limited. It's important to know how we got here, and I realize that may not have been the point, but I do want to say that it's important to have exhausted medical therapy in this situation, that an intervention here is to improve quality of life and functional status, and that a patient might opt, knowing the risks and benefits of the procedure, not to have a stent or not to have revascularization, which is okay also, even if they've gotten to a point where maybe they failed supervised exercise or structured exercise therapy or other pharmacotherapy if they're a candidate like silostazole. And the guidelines touch on all of that. But your question for me was, what's the best approach to antithrombotic therapy? And so I think this slide here summarizes nicely the recommendations we have. So moving from the top to the bottom, we have a class 1 recommendation for antiplatelet therapy just generically, right? After either endovascular or surgical revascularization. We also have a class 1 recommendation with an even higher level of evidence. There's 2 randomized trials supporting this for using dual pathway inhibition with rivaroxaban 2.5 milligrams twice daily and aspirin 81 milligrams once daily. And that's true after either endo or surgery. The difference there being that we can actually, and we have evidence to support that we can reduce both MACE and MALE when we use that regimen. So I think that's a really important class 1 recommendation. There was a question in the Q&A in the chat that I think may have already been addressed by Arthur, but I want to sort of resurface it, which is just, what does recent mean? And the guidelines don't necessarily define recent, but the clinical trials did, and specifically Voyager PAD, which used this regimen, defined recent as someone who's had revascularization within the past 10 days. Now, does that mean that someone who's 11 days out is not a candidate? I doubt it, but just to be completely clear, that's the way the trial was designed. As we continue to move down this slide, we have other recommendations for antithrombotic therapy that are not quite as strong. So we've got a class 2A for DAPT for anywhere from 1 to 6 months after endovascular revascularization. We've got a 2A for adding a single antiplatelet agent after endovascular revascularization, if there's full intensity anticoagulation on board as well. And then we have a 2B for DAPT for a month after surgical revascularization if a prosthetic graft was employed. And as some of those data, for example, the very last one that I mentioned, come from sub-analyses of clinical trials. So CASPAR was a study that looked at surgical revascularization. And in the vein graft arm, there wasn't a benefit of DAPT, but in the prosthetic arm, there was. And so that's why it's only level of evidence B, but it's still from a randomized trial and still worth considering in patients who meet this description.
You know, as I look at this, and I'm thinking in particular about that second and third recommendation here. So somebody who's coming forth to have, let's say, an endovascular revascularization. I think many practitioners historically have relied on DAPT, often extrapolating data from the coronary literature about the use of antiplatelet therapy. And I'm seeing here that we now have a stronger class recommendation, right? Class 1 to go after dual pathway. How do you get systems and clinicians to change that behavior to really embrace a class 1 type of recommendation here? And then when do you say, no, maybe that's not the right thing to do? We should stick more with an antiplatelet focused approach.
Well, I do. It's a great question. I do want to emphasize that these aren't necessarily mutually exclusive. You don't always have to choose one versus the other. And in fact, Will Hyatt did a really nice sub-study where he looked at people who were on DAPT, but also on low-dose rivaroxaban from this study, right? And so we know that at least for the first 30 days, that DAPT doesn't increase major bleeding. We know this from randomized data. And even when you look out to 6 months, although numerically there was an increase in bleeding when patients were on a P2Y12 inhibitor plus dual pathway inhibition, there wasn't a statistically significant increase in major bleeding as defined in the trial. So I think it's okay to use both. It depends on your patient. It depends on their bleeding risk. If you're taking care of someone who's at high bleeding risk, then I think you're going to want to avoid this. But in other situations, it may be perfectly appropriate.
Got it. And are there things that maybe our pharmacists, our nursing colleagues can do to help get this in front of clinicians? I mean, are we building this into order sets? Are there ways we can make this more readily available so that patients, when appropriate, are getting this class 1 recommendation therapy?
I think that that this is a question about implementation science, right, and a really critical one. We can have all the randomized trials in the world, and we can summarize them really nicely in a document like the lower extremity PAD guidelines. But at the end of the day, what we're trying to do is put this knowledge into practice. And so I think you've already mentioned some very effective strategies. From a monitoring standpoint, often participating in quality registries that capture data like this can be useful. You can look back and say, as an institution or as an operator or as a care team who's got this patient that they're taking care of after this intervention, how are we doing? How many of our patients received therapies that are deemed class 1 as an example. But you can also do things to increase the likelihood that will happen because inevitably there are these care gaps. And order sets are one way to do that for sure. I think they can be really important when you're talking about things like same-day procedures where you just simply don't have as much time with the patient, as much time to think about these things. They may be gone in 6 hours and home, and you may miss an opportunity. But an order set is, if you program this into the order set, is one way to avoid making that mistake.
So as we've mentioned, there are a whole bunch of recommendations across kind of a spectrum of patients with symptomatic PAD, including those with claudication and CLTI. Amy, I want to turn to you. When I saw this figure, at first, it was kind of inspiring because there's so much green, meaning we have so many of these level 1 recommendations, which means these are things we can do for patients with PAD. And then I started to say, oh, but I'm overwhelmed. There's so much to do. How do you, as a clinician, approach the selection, not just around the antiplatelet therapy, but then all of these other things that we need to do for good medical care of our patients with PAD?
No, thank you. It's a great question. And I think that I want to kind of look for what are those foundational approaches that we're going to do for all patients with PAD. And so, as you said, it is awesome that there's so much green on this screen for those class 1 recommendations. And if we move to the left-hand side of the screen, those were the asymptomatic PAD patients. You can see that even if somebody's asymptomatic, truly asymptomatic with PAD, we still want to work on their cardiovascular risk reduction approaches. So making sure they're on lipid-lowering therapy, whether it's a statin or if their lipids aren't at goal on statin, considering PCSK9 inhibitor therapy, antihypertensive approaches, managing their diabetes if they have it. Smoking cessation is critical. And I love that the preventative foot care is just really embedded in our approach for our care of patients, because it is critical that patients are learning to not only examine their feet or have family members do it, but wanting to make sure that they're going to see the podiatrist, they have the appropriate footwear, and that we're really working to prevent skin breakdown. And then, vaccinations, influenza and SARS, COVID vaccination. And certainly you can see for the single antiplatelet, it's going to be a lower level of recommendation, a 2A for truly asymptomatic PAD. Then if we go to the right-hand side of the screen, and maybe if we start kind of bottom up, because this is where those common themes are going to be for that foundation of how we care for all patients with PAD, you can see that we have, again, that vaccination, that preventative foot care becomes even more important when somebody has symptomatic PAD, especially as they get to that chronic limb-threatening ischemia. This is mission critical to be able to make sure that they are seeing podiatrists and wound care specialists if needed. The Solostazole can be certainly useful for chronic symptomatic PAD to help improve kind of pain-free walking distance. Recall it's contraindicated if patients have symptomatic heart failure, but otherwise it can be a good tool. And then that structured exercise or supervised exercise therapy or SET, it is fantastic that it's been covered by Medicare since I think it was 2017 as a result of so much advocacy and work. And as Herb was talking about with this last case, for somebody who's going to intervention, we know that for many patients, they can do very well with supervised exercise therapy. This is from the CLEVER trial, but absolutely still need for intervention in many patients. Smoking cessation, again, cornerstone of how we're going to be caring for all of our patients with PAD, as well as that cardiovascular risk reduction, lipid lowering, antihypertensive, and diabetes. And then we get up to the antiplatelet antithrombotics. And this is just a wonderful summary of what we've Geoff's been walking us through with these last few cases. So on that left side, or I guess more the middle here, for that no recent revascularization, the guidelines were written such that for the patient in front of you, as Herb was talking about, for somebody who's at a higher bleeding risk or who's had a prior stroke, they weren't included in the COMPASS trial. So you're going to be choosing a single antiplatelet for them. But if for individuals who are at a lower bleeding risk and you really want to be, more intensive about reducing their MACE as well as their leg events, I really think now is the time to be changing our perspectives, on this dual pathway. And I think in terms of the implementation science part of it, I think we're going to have to change the narrative, and this document for the guidelines as well as webinars like this go a huge way just to help educate all of us that kind of gone are the days for many patients of just thinking about a single antiplatelet and then we've checked that box. But we need to expand our thinking for that dual pathway where their patients are getting the low dose rivaroxaban and low dose aspirin. And I think it speaks to the importance of our care team really working to educate patients about the why and reinforcing that, no, this isn't a full dose blood thinner. If you have AFib or if you've had some sort of embolic event, your needs for anticoagulation are going to be different. But really explaining why this dual pathway is so valuable. And then that recent revascularization side of the screen highlights what Herb was just talking about with that last case.
So as we mentioned, this screen is just full of green. And as my daughter knows, anytime she's in the back of the car and she sees that green light, green means go. And there's so much that we all can do to really move forward the care of patients with PAD. But of course, when you see a lot of green, you always have to wonder, is there any red? And so Herb, red means stop. What are the things we aren't supposed to do? And in particular, I'm thinking about that patient who has PAD and we're thinking some anticoagulation is good, right? We talked about dual pathway. If some is good, is more better? Where did the guidelines come down there?
Yeah, a very important question, and actually one that came up a number of times already today in the chat. People asking about or reporting that they're seeing a lot of anticoagulation simply because a patient has PAD or simply because maybe they underwent revascularization. And when I say anticoagulation, I mean full intensity, full dose. Mm-hmm. And as you just heard from Amy, sure, if there's an indication for that, like atrial fibrillation or some kind of thromboembolic event, that makes sense. But we have several randomized trials that have actually looked at these questions or this question about full intensity anticoagulation. both in people with just simply with PAD and also in those who've undergone lower extremity bypass grafting. And what we're seeing is that there is a harm that far outweighs any potential benefit, if there's benefit at all. We haven't seen any benefit at all in those with just pure PAD, but no revascularization, but we've certainly seen an increase in major and even life-threatening bleeding. And then in patients who've had revascularization, specifically lower extremity bypass grafts, there doesn't appear to be any benefit with prosthetic grafts. There may be some patency benefit with venous grafts, but again, far outweighed by the bleeding risk. And so there is a recommendation against using full intensity anticoagulation in patients with PAD simply because they have PAD or they've undergone revascularization. There is a harm. It's not that there's no benefit, it's that there's clearly a harm, and hence the class 3 here.
So that enthusiasm for doing more, we really got to keep that in check and make sure we're right sizing our antithrombotic therapies for the patients and what's in front of them. Well, this has been really an excellent discussion. I want to thank you both for bringing us through the guidelines here. Arthur, I want to bring you back in because I'm sure there has been just a lot of question and conversation in the chat. And do you want to help navigate us through that over the next 10 minutes or so?
Yeah, you betcha. And thank you so much for the presentation. This has been really, really great. I love the conversational style. Yeah, so I looked at the pre-submitted questions and then the questions that are coming in, and then kind of predictably, based on who our audience is, they kind of filter into a few different themes. And the first one, you just addressed it, but we got to go there, is the use of therapeutic anticoagulation therapy in the setting. And we in the anticoagulation world kind of get forced into this situation where it's not our call to make, it's the surgeon's call, but they feel obligated to anticoagulate. And now this is not, the patient has PAD, so put them in an anticoagulant. These are almost notoriously, surgeon was called at 2 o'clock in the morning to revascularize when somebody's, in the setting of acute limb ischemia, or they get in there and they say, well, the patient doesn't have, florid atherosclerosis. We're suspecting this is from an embolic source, or it's in the setting of an aneurysm, or they've had a vascular graft that failed, and we're trying to maintain patency of the redo. Are there ever any situations where anticoagulation therapy is, throwing the kitchen sink at it and acceptable? And how should we non-surgeons navigate this?
I mean, these are great questions. I'll maybe just, continue my comments and then let Amy and Geoff weigh in also. I think there certainly are situations where it makes sense, right? If this was an embolic event that led to acute limb ischemia, sure, right? I mean, that would make sense if it's thromboembolism. So I don't think anybody would argue with that. If someone has an aneurysm, abdominal aortic aneurysm, and we think that was the source of an arterial thromboembolism, yes. So it doesn't just have to be AFib as an example, or a left ventricular thrombus. It doesn't have to be a cardiac source. It could be an aneurysmal source, right? Yeah, that makes sense. I think it's the routine use, absent those indications, that not only doesn't make sense because there's not a benefit. We've shown that there's not a benefit, but because of that harm I was speaking to earlier, that we're exposing people to a bleeding risk without anything in return.
No, I would agree. I think that specific clinical scenario of acute limb ischemia, when someone's first coming in, they have a cool pulseless foot and trying to figure out revascularization strategies, absolutely putting that patient on anticoagulation, full dose anticoagulation, while you're figuring out what needs to happen next. But I think we're all speaking to more of that kind of chronic long-term anticoagulation where you're like, oh gosh, I loved that Geoff put up is if some is good is more better. And I think that as you've heard, the answer is no for that long-term approach.
And I just add briefly to this, Arthur, there was a really nice study where they looked at limbs that had either chronic limb-threatening ischemia or acute limb ischemia. And what we find is there is a lot of thrombosis that's happening in the lower limb, very different than what happens in the coronary space. But that's why this dual pathway makes a lot of sense, because you get both the antiplatelet effect that we're used to in a traditional atherosclerotic bed, and you get some of the anticoagulant, the anti-10A activity from the very low-dose rivaroxaban. So it's that together, both of those sort of address this unique aspect that you see pathologically in those lower extremities, even when they have an acute limb ischemic event where you can't find a more proximal embolic source. So you got to separate embolism versus thrombosis.
Excellent point. I think that we need to go back and remind our colleagues that anticoagulants are, preventative. Even in the acute setting, they are preventative medicine. They don't treat clot per se. They don't make clot go away. And so it's important for us to remember what the goal is, especially in a chronically occluded leg, for example. So thank you for that. The other theme that crops up that I think we should talk about is antiplatelet therapy, and specifically in patients with another indication for oral anticoagulant. So, I want to go back to the question, Herb, that you talked about with what does recent revascularization mean? So how would that translate into a patient who doesn't have an indication for an oral anticoagulant? Perhaps we're talking about DAPT duration versus a patient who does have an indication such as atrial fibrillation or history of venous thromboembolic disease. And when is antiplatelet appropriate, and for how long?
Yeah, for me, I think it comes down to if someone has an indication for anticoagulation, and they also have underlying atherosclerosis, and you're contemplating whether to treat them with both, it comes down to their bleeding risk, right? So if they're at high bleeding risk, I think you may not want to expose them to both, and you might just lean in favor of an anticoagulant in that situation. There are other situations where that risk isn't as high and where there's a class 2 recommendation to add an antiplatelet agent in that setting, and so it's reasonable to do that. It's just not that you should take that approach in everyone. I think it's after a thoughtful review of their risk of bleeding. I don't know if Geoff or Amy, you have a different perspective, but that's how I look at it.
Well, the real question I think that I would bring back is, what does recent revascularization mean, and how does it differ from what we kind of know to be the standard of care in the coronary vasculature?
Yeah, I mean, the only example of recent revascularization that we really can allude to is as it was defined in Voyager PAD, right? I mean, it prospectively defined recent as within 10 days. I think we have to be a little bit careful because that's a pretty narrow definition. And again, this becomes a judgment call. It's just, how do you want to reduce these findings to practice? And how are you going to draw the lines when you try to extrapolate the findings from a randomized trial? I mean, we do this every day with trials, right? What is this, or does this apply to my patient, or does it not? I think if I had a patient who was 20 days out, I don't know that I would treat them differently. If they were 2 years out, it's sort of a data-free zone, and it's a bit of a stretch for me to say, well, anyone at any point in time out from a revascularization procedure would benefit from dual pathway inhibition. I don't know that I feel as comfortable there, but closer to that 10-day mark, I don't think we have to cut it off at 10 days. Again, this is opinion. We don't have data to drive those decisions.
Yeah, so maybe I'll ask Geoff specifically. Patients, atrial fibrillation patient, anticoagulated, goes in and has a peripheral stent. So now you've got, foreign material. That we're often treating that stent. Is that 30 days is that the 10 days apply there?
So I would integrate 2 pieces of information to make that decision. As Herb recommended, right? You got to look at the bleeding risk because that's really going to drive it. But I would look at the Voyager PAD study here, and I think it really helps inform us. If you take the AFib away, Voyager PAD really told us that low-dose Riva plus aspirin is the best strategy to use. And if you want to use dual antiplatelet therapy, it's reasonable to use that for up to a month, but then you start to get some concern about bleeding risk that's continuing thereafter. Now, if you take and you put the AFib back in, so now that Riva that we were doing at 2.5 twice a day is going to jump to 20 once a day, or it's a Pixaban 5 twice a day, or it's warfarin, right? We're greatly increasing the level of anticoagulation therapy. We're greatly increasing the bleeding risk. So now I'm much more concerned about having DAPT, dual antiplatelet therapy, plus that high full intensity anticoagulant. So I may be talking about not doing DAPT at all, or limiting it to only 7 days, and seeing how quickly I can get to single antiplatelet therapy, which we saw is a guideline recommended. That's a level 2 recommendation for that patient. And then if they're stable, maybe it's at 30 days, maybe it's at 3 months, something like that. Then you peel off the antiplatelet if you're worried about bleeding risk. So you're going to have to kind of step it down that way.
Excellent. Thank you so much for that clarification. This is what we deal with every day. You know, there were we had some questions submitted asking about the difference between PAD and PVD. In my mind, those are the same thing. Just want to kind of do some little rapid fire questions. Those are the same disease to you, right?
You know, for me, you know, peripheral vascular disease, right, it encompasses all vessels. So if you're a purist, then PVD includes lymphatics, veins, and arteries. So I tend to use it that way. And when I'm talking about atherosclerotic disease involving non-coronary arteries, and in this example, the lower extremities, when I say PAD, I mean arterial or artery disease.
Yeah, just don't use PVD. It's not specific enough. People don't know what you're talking about. And if somebody else uses it, ask them to clarify. Do you mean arterial disease, PAD? Right. And it's, you know, that just ask them to clarify that. Be specific.
Yeah, as evidenced by the fact that it was a question, like, what do we mean? So excellent. You know, I think that's pretty much, if we think about the groups of questions, that pretty much covers most of them. I think maybe we'll go ahead and kick it back to the closing. Again, thank you guys so much.
Well, that is great. And I want to thank all of our presenters today. Arthur, thanks for moderating those Q&A. Herb and Amy, thank you so much for sharing your invaluable insights, for leading this effort as a community, especially as somebody who sees a lot of patients with vascular disease. This is a guideline update that we have been looking forward to for a long time. Thanks for sharing your wisdom. We really appreciate you being here with us today.
Thank you.
Thanks for having us.
Appreciate the chance to be here.
Great
For our AC
conversation.
Forum colleagues, we know that we have these monthly webinars, and the next one is one you do not want to miss. This is coming up on Thursday, July 11th. We're going to have an amazing panel talking about differences in quality of anticoagulation care according to ethno-racial groups. This is a really important topic, especially for those of us here in the United States. So please join us for this really thoughtful discussion on anticoagulation care. And of course, we are now less than a year away from our national conference on anticoagulation therapy. It's coming up April 3rd through 5th in Washington, D.C. Come see the cherry blossoms. It's going to be an amazing conference. Registration will open this fall, but put it on your calendar. You do not want to miss it. Thank you, everyone, for joining us, and we look forward to seeing you next month.